lecture. So the pathophysiology is simple. In liver cirrhosis, just think scarosis for cirrhosis. Normal healthy tissue gets replaced with scar tissue, making the liver hard like a rock. Now, what causes this? Well, think about it here. Anything that can scar the liver in scarosis. So alcohol abuse can scar the liver. Chronic hepatitis with inflammation can scar the liver. And even cystic fibrosis, where we get serious mucus in cystic fibrosis. This mucus can build up and clog the entire body, including the liver. Now, what does the liver do? As you know from our liver song, the liver acts like a recycling company with 4 major roles and responsibilities: detoxing ammonia, a waste product of protein, drug metabolism, storing glycogen, producing bile coag factors, and albumin. So coag factors are our clotting factors to prevent bleeding, and albumin is used for drug transportation as well as to attract water into the vascular spaces. Now I know that's a lot, so let's break this down one by one. Simply think the liver produces ABC. A for albumin, B for bile, and C for clotting factors. So starting with albumin. Albumin is a protein inside the blood that does 3 things. It transports drugs inside the body, it also attracts water to keep it inside the vascular space, and also binds with calcium to make bones strong. So just think albumin attracts water as well as attracts drugs and binds with calcium. Now, another memory trick that I personally used during nursing school is to think of albumin as Al Pacino from that movie Scarface, for scarosis. Now, Scarface is an old movie from the 80s about a drug lord who transports drugs, and he's near Miami, basically near the water, to help remind me of water. So just think here, when the liver fails in scarosis, the body can't produce albumin, so we get hypoalbuminemia. So drugs don't get transported properly, and water builds up inside the body because albumin isn't there to attract the water. And this causes edema and third spacing, like ascites, where the abdomen is filled with fluid. So just think of the double A's. Ascites is for abdominal fluid. And lastly, hypoalbuminemia, we see low calcium inside the blood due to low binding. So we see weak bones with the big risk for fractures and even osteoporosis, those porous bones. And lastly, the 2 classic signs of hypocalcemia, or basically low calcium, is Trousseau's. We have an arm twerk with a blood pressure cuff on, and also Chavastics, which is a smile when you stroke the side of the cheek. The next thing is B for bile, which we call the bile bus, helping to scoop up excess cholesterol and bilirubin, taking it from the body and into the potty via the bowels. Now, cholesterol, as you know, are those lipids that clog the arteries if we have too much, leading to major cardiac issues. And bilirubin is just those dead RBCs, or basically red blood cells. So when the liver fails, then we get a buildup of both, high cholesterol and high bilirubin, which bilirubin turns the body jaundice, making the entire body yellow. So we get yellow skin, yellow eyes, specifically the white part of the eye, called the sclera. So Kaplan mentions cirrhosis. Expected laboratory results is elevated bilirubin. And this is due to the lack of bile, or the bile bus, to help carry this bilirubin out of the body and into the potty. The last letter in our ABCs is C for clotting factors, or coagulation factors, which helps the blood to clot. So with liver disease, the blood doesn't clot fast enough, leading to huge bleed risks. Always our number one concern is bleeding. So naturally, we see longer clotting times, resulting in longer coagulation times on the coagulation panel when we look at lab results. So Hesse mentions, which complication is a patient with cirrhosis at risk for? And the answer is bleeding. And another question, which hematological symptoms might be noted in a patient with cirrhosis of the liver? Select all that apply here. Anemia, low blood volume, leukopenia, low white blood cells, and a big one here, thrombocytopenia, low platelets, under 150,000. Now, before we get ahead of ourselves here, just focus on the thrombocytopenia here. We'll talk about anemia and leukopenia when we start talking about portal hypertension. Okay, now the second role of the liver is to detoxify ammonia, which is a byproduct of protein metabolism. So just think of ammonia as a protein wrapper. It's trash. The body will absorb the protein and trash the waste, the ammonia. So the liver converts ammonia into urea, pushing it into the blood as urea, coming out as blood urea nitrogen when we measure BUN. And then it's excreted by the kidneys as urine. So in liver disease, ammonia becomes elevated, leading to a key term here, so write this down, hepatic encephalopathy. Fancy words for a cloudy, toxic brain. Clients will present with twitching extremities in the arms and legs and severe mental status changes, like confusion, sleepiness, and even bizarre behavior. So as he mentions, during an assessment of a patient, the nurse finds asterixis, which is basically just tremoring of a hand, twitching of the extremities, and notice that the patient is displaying inappropriate behavior and disoriented. Which condition does the nurse suspect? Hepatic encephalopathy. The key terms there is inappropriate behavior, disoriented, and the twitching of the extremities. Now, the third role of the liver here is drug metabolism, or basically breaking down drugs. So in liver disease, the liver can no longer break down drugs, so drug toxicity builds up inside the blood, leading to major adverse effects. So always be cautious of the toxicity, even when you're giving enough medication. They can become very toxic very quickly. Now, a little side note here. We always avoid acetaminophen, brand name Tylenol, since it can damage the liver. Now, the antidote to acetaminophen is acetylcysteine, brand name Mucomyst. So just look for the double A's, acetaminophen and acetylcysteine. Lastly, the liver stores glycogen, which is stored glucose, mainly found in the liver and muscles. So glycogen, just think glucose storage. It's used as energy reserves when the body needs more glucose, like during a marathon or even an intense exercise. Now, as far as the signs and symptoms, again, just think of the patho here. Cirrhosis, think scarosis. The liver is filled with scar tissue, becoming hard like a rock. So, do you think blood flow can get through this hard rock here? Well, no. So this backup of blood results in increased blood pressure within inside the liver, backing up into the portal vein, which connects the pancreas, spleen, stomach, and intestine. So naturally, these will enlarge, specifically the spleen, called splenomegalia. Just think of a big ol' mega spleen here. And we see an enlarged esophagus called esophageal varices, which we'll cover in a moment. Now, this high pressure inside the portal vein is known as portal hypertension. Over 10 millimeters of mercury in the portal vein here. Naturally, blood flow to the liver will back up and fluid will now spill over into the abdomen, into that third space. This is called ascites. Just think of a huge fluid-filled abdomen with ascites. Now, as fluid builds up in this third space, clients will actually look like they're pregnant as they fill up with this fluid. Naturally, we have fluid backing up everywhere from this rock-hard liver. So esophageal varices, which we just talked about, is the enlargement of the veins inside the esophagus, the tube that connects the throat and the stomach. As blood backs up from the liver, causing portal hypertension, it forces major pressure on the esophagus, causing the vessels to bulge to the max, kind of getting thin from all that pressure, like a ticking time bomb or an overfilled water balloon, just waiting to explode. Very, very deadly. Now, the scary part is that it goes unnoticed until it ruptures from the slightest amount of pressure, say from straining on the toilet, or coughing, or even sneezing too hard, or even a new NG tube. So once the varices pops, it will actually cause an explosion of blood. We're talking heavy bleeding, filling up the stomach and leading to vomiting out all that blood, which can lead to hypovolemic shock or hemorrhagic shock from all that blood loss. But really the biggest complication immediately is the airway obstruction. So to protect the airway, always turn the patient to the side. Okay, now the big key point to write down for any client with esophageal varices. Remember, no nasogastric tube, or basically no NG tube, and no straining during bowel movements, no pressure at all. Remember, this esophagus is like a ticking time bomb, just waiting to explode. So common NCLEX questions include a client with a history of cirrhosis with suspected gastroesophageal varices. Which order would the nurse question? The new nasogastric tube. Yes, always question any new NG tube. And a client with cirrhosis, portal hypertension, ascites, esophageal varices, all the things, right? Which of the following is correct patient teaching? Avoid straining. Yes, always avoid straining when having a bowel movement. Now, Kaplan mentions the first action when a client with cirrhosis begins to vomit blood after a meal. Obtain vital signs. The probable cause is esophageal varices. And Hesse mentions which nursing intervention would be the highest priority in managing a patient with a ruptured esophageal varices. Protecting the airway. Yes, as mentioned before, we always do the ABCs. A for airway always comes first. And lastly, a patient with cirrhosis and esophageal varices is vomiting. The nurse notes hematemesis, or basically vomiting blood. Which action should the nurse take first? Place the client in side-lying position. Yes, again, we protect the airway first. Now, in terms of hepatic encephalopathy, as mentioned before, this is that cloudy toxic brain from the high levels of ammonia in that protein. So the key signs to write down is twitching extremities in the arms and legs, known as asterixis, and mental status changes, seen as confusion or bizarre behavior, as well as sleepiness. Now, select all that apply questions love to ask about assessments for hepatic encephalopathy. So, write this down. The key assessments include assessing hand movements with arms extended. Write that one down. Arms must be extended. Assess mental status with those from the previous shift, and assess recent blood draws for ammonia levels. Again, write those down. I can almost guarantee you it will come up on your exam. Now, the top miss NCLEX question from this section. Which assessment would indicate if a client with cirrhosis has progressed to hepatic encephalopathy? Select all that apply. Ask the client their date of birth, name, date, and location. Yes, these 4 questions are to monitor mental status, to see if the client is oriented. Tell the client to extend their arms. Yes, the key term there is to extend the arms to assess the muscle twitching. And lastly, compare the ammonia blood levels with that of previous shifts. Yes, ammonia levels should not be going up. If they are, it will cause more hepatic encephalopathy. Now, don't let the NCLEX trick you here. For hepatic encephalopathy, we are not assessing the skin for thinning blood vessels, like spider veins. And we're not assessing the eyes or skin for jaundice, that yellow skin. These will typically be present with any client in liver failure, not specific to hepatic encephalopathy. So just make sure to know your key assessments for hepatic encephalopathy. Now, Saunders mentions a client with cirrhosis shows signs of hepatic encephalopathy. The nurse should plan dietary consultation to limit which ingredient. And the key answer was protein. Yes, protein has the ammonia waste. Remember, ammonia is the protein wrapper, the waste around the protein, which causes the hepatic encephalopathy. So limiting protein will limit the ammonia. Now, in terms of liver failure labs, big NCLEX tip, write these down. They love to come up on select all that apply questions. So ammonia will be high, causing the hepatic encephalopathy, our cloudy brain. And the ABCs of the liver will be all jacked up here. So A for albumin, that's going to be low, under 3.5, as well as calcium will be low, since calcium binds to albumin. And we'll also see low platelets. Now B for bilirubin, that'll be high, since our bile bus is out of commission, not scooping up little Billy, our bilirubin, causing the body to become jaundice yellow. And C is the coagulation panel, or the clotting factors. Basically, our clotting times will be high. So we'll have high PT, PTT, and INR. So a higher risk for bleeding. Bruising is very common with these clients. And lastly, we'll have elevated ALT and AST, which are common really for any liver disease client, from cirrhosis to hepatitis and even others. So you really don't need to memorize the ALT or AST numbers. Most exams will give you the ranges. Now, a top miss question: for which blood lab values are expected to be elevated in a client with worsening cirrhosis? Select all that apply. So just slow it down here before you look at the options. So just think ammonia, bilirubin, and prothrombin time, the PT, will all be elevated. The only two that are really going to be low is albumin and calcium here, because albumin is that protein that the liver produces, and since albumin binds with calcium, both will be low together. Now, don't let the NCLEX trick you here. They always try and get you to choose albumin and calcium, saying that they're elevated. But no, they will always be low. Now, another sign and symptom is pruritus, that itchy skin. You see, as toxins and bile salts build up under the skin, this causes major itching. Just think about it here. The recycling detox filter, the liver, is broken, so the body's naturally filling up with waste products. So the 4 key points that love to show up on exams and select all the applied questions, it always revolves around protecting the skin and avoiding the scratching. So write this down. 4 key points. Number 1, apply a cool, moist cloth to the affected area to soothe the skin. Not a hot shower or a hot bath. Always keep it cool. Number 2 is applying moisturizing cream over unbroken skin to protect the skin. The key term is unbroken skin. So moisturizing cream is good. Now, number 3 is wear long sleeve clothes and cotton gloves to avoid the scratching here. And number 4 is trim the fingernails short to prevent skin breakdown if the client accidentally scratches themselves. So I'd recommend pausing your screen and writing these 4 things down. Now, for a top missed NCLEX question here. A client with worsening liver failure presents to the med-surg floor. Which assessment finding should the nurse expect? Select all that apply. So just slow it down and look at the key terms. Worsening liver failure, and it's looking for an assessment finding here. So, option 1, an enlarged abdomen from ascites. Yes, ascites is that abdomen filled with fluid. And bruising marks all over the skin. Yes, from the lack of clotting factors leading to easy bleeding, resulting in bruising. And fatigue and possible confusion, for sure, from possible elevated ammonia levels leading to hepatic encephalopathy. How about sclera that appears yellow? Yes, from jaundice. Remember that building up of bilirubin inside the blood makes the entire skin look yellow like a school bus. So just think of your patient like a little lemon here. It's big and it's yellow and it might have some bruising. And very lastly here is reports of itchy skin. Yes, from all those toxins building up inside the blood. Now for a little test tip for your pathophysiology exams on the highly tested alcoholic cirrhosis manifestations, or signs and symptoms. So number 1 is the initial stage. We see a fatty liver with enlargement of the liver. Now this stage is reversible with cessation of drinking, or fancy words for stop drinking. We can reverse the problem. Now progressing into stage number 2, the second stage of alcoholic hepatitis. This is irreversible fibrosis. Fancy words for scar tissue formation within the liver. And lastly is the third stage. This is known as end-stage cirrhosis. Fibrotic tissue replaces normal tissue and little function remains. This is why we say scarosis for cirrhosis, because normal tissue is replaced with scar tissue. Now for diagnostics, a liver biopsy can be taken to analyze tissues. So key point here is after the procedure, we have clients lay on the right side to prevent bleeding. So we always put pressure on anything that is bleeding. In that same way, we want to put pressure on the liver to prevent bleeding. Now for interventions, there's many here, so write this first one down. For ascites, we do a paracentesis. So again, remember A for ascites is A for abdominal fluid. From all that portal hypertension where fluid now overflows into the peritoneal cavity. So in a paracentesis, the HCP simply pokes the abdomen with a needle to drain the fluid. Now there's a lot of nursing actions prior to the procedure, so write these down. They love to come up on NCLEX questions. Have the client, number 1, empty the bladder to avoid poking or perforating the bladder. Number 2 is vital signs. The key number here is to monitor for blood pressure, since clients who are getting fluid drained can go into shock, meaning severely low blood pressure. Number 3 is we measure the abdominal circumference and take the client's weight. That one is a big one here. It's always tested. And we have to measure how much fluid was taken out of the abdomen. Now lastly, number 4 is head of the bed up in high Fowler's position to keep that fluid in one place and to help the drainage here. So Hesse mentions, a nurse is assisting with the paracentesis for a patient with ascites caused by cirrhosis. Which action should the nurse take first? Have the patient empty their bladder. Yes, we always empty the bladder first, so make sure to write down the 4 key points before a paracentesis. Then we can also give albumin IV to treat the hypoalbuminemia. Remember, albumin attracts water, transports drugs, and binds to calcium. So it attracts water like a magnet to bring fluid back into the vascular spaces to help decrease ascites, which causes an increase in blood pressure and bounding pulses as fluid gets drawn out of the abdomen and into the blood vessels. So once inside the blood vessels, we give eye-ending diuretics like furosemide to drain that fluid from the body and into the potty. Now, here's the key point for exams. How do you know if albumin has been effective? Well, write this down. We assess the vital signs. They must remain in, key term, normal limits. That's how you know if albumin has been effective. A big key point for the NCLEX there, so write it down. A lot of students get this wrong all the time. Now, don't let the NCLEX trick you here. Albumin effectiveness does not depend on the reduction of abdominal circumference with ascites, and it does not resolve muscle tremors or twitching in the arms and legs. That's mostly for hepatic encephalopathy. So remember, albumin is effective if vital signs are within normal limits. All right, that wraps it up. Thank you so much. Now for cholecystitis. This is inflammation of the gallbladder, typically caused by gallstones, also called cholelithiasis. Now these little stones block the ducts that lead out of the gallbladder, resulting in a backup of bile, which causes inflammation. Now the main risk factors include a high-fat diet, obesity, as well as age over 40. And for some reason, females are more susceptible than males. Now the signs and symptoms are key, so write this down. Number 1 is right upper quadrant pain that radiates to the right shoulder, since this is where the gallbladder is located, right here near the liver. And we also see fevers with chills, as well as tachycardia, since the inflammation can lead to infection. Now again, write these 3 down and know the location here. Always highly tested on Select All That Apply questions. Now, don't let the NCLEX trick you here. Not left upper quadrant pain that radiates to the back. That's typical of pancreatitis on the other side of the abdomen. So Kaplan mentions, priority findings for acute cholecystitis include tachycardia. Now, other signs include vomiting this greenish yellow bile, and pain will get worse from eating high greasy or high fatty foods. Now, if we have a blockage in the bile duct due to a stone, the patient may show signs of high bilirubin, like jaundice, dark urine, yellow of the eyes, and even clay-colored stools from that elevated bilirubin. And also, the lack of enzymes from the pancreas can lead to statorrhea, that fatty stool, from excessive fat inside the stool, from the lack of lipase. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study. Now for hepatitis. This condition refers to inflammation of the liver, commonly caused by a viral infection. And non-viral causes are typically caused by alcohol and even autoimmune diseases, where the body attacks itself. Now there's 5 different types of hepatitis: A, B, C, D, and E. But really the most tested here are B and C, so I bolded them here. So starting at the top, type A is transmitted by fecal-oral route, typically through contaminated food. And B and C are typically transmitted from blood and body fluids. Now D is a co-infection with type B, and E is the fecal-oral route, typically contracted from contaminated drinking water. So the memory tricks to know for exams is A, think anus to mouth. For hepatitis B and C, just think blood cultures as well as sex. And E, just think E. coli is in the water from drinking contaminated water. Now in terms of causes and risk factors, for B, C, and D, we have blood and body fluids. So IV drug use as well as tattoos or even body piercings, and even sharing razors or unprotected sex. So a common NCLEX question talks about modes of transmission for hepatitis C. Select all that apply. So just think hepatitis B and C is from blood cultures, B and C, as well as body fluids. So option number 1, blood, is correct. Option 2 and 3 are incorrect here. Remember, we're looking for blood and body fluids. And option 4 and 5, semen and vaginal secretions, yes, that is correct for hepatitis C. Now, in terms of signs and symptoms, when caused by a virus, which is the most common, we see flu-like symptoms. So we see a headache, fever, fatigue, also called malaise, as well as nausea and vomiting. And a key term here is elevated liver enzymes, because in hepatitis, we just have inflammation of the liver. So naturally, we'll see an elevation in liver enzymes with elevated ALT and AST and elevated bilirubin. Now, normal for any liver disease, we see common signs like itchy, also called pruritus, from bile salts that build up under the skin. We get that elevated bilirubin, as mentioned before, so we'll see jaundice, basically that yellowing of the skin and the eyes. We'll also have colored urine, as well as clay-colored stools, typically described as pale stools, from all that bilirubin spilling over into the bowels. We'll also see elevated PT and APTT. That leads to bruising from the lack of coagulation factors, as well as low albumin. So we see edema since albumin is not there to attract the water back into the blood vessels. Now, a little side note for pathophysiology: the 3 stages of hepatitis with correlating signs and symptoms. So number 1 is the prodromal or preicteric stage. This is defined as general, non-specific manifestations like malaise, fatigue, muscle aches, nausea and vomiting, and even anorexia. Moving on to the second icteric stage. These manifestations are a little bit more serious. So we see jaundice, light clay-colored stools, and even darker urine. And lastly, number 3 is the post-icteric stage. This is known as the recovery stage. So Sonder mentions, the nurse is teaching the client with viral hepatitis. This disease is characterized by which specific assessment finding? Select all that apply. So jaundice, clayed color stools, elevated bilirubin levels, as well as dark or tea-colored urine. Now, all these signs are from that elevated bilirubin that spills over into the bloodstream, making the entire body yellow. So this is typical for any client with liver disease, specifically with cirrhosis as well. And we go into way more detail in that video. Now, for a top missed NCLEX question about hepatitis. A client is admitted with hepatitis and complains of constant itching. Which intervention would the nurse recommend? So, option 1, applying a moisturizer. Option 2, avoiding the sun, yes. And option 3, applying a cold press, yes. And option 4, applying a hot pad, no, we want to avoid the hot pads and choose the cold. So option 1, 2, and 3 are the correct ones here. So itching is a very common complaint after hepatitis, so it's best treated with a cold press, moisturizers, as well as staying out of the heat. Now in terms of diagnostics, the antigens are not highly tested, so I recommend not focusing on that too much. But a liver biopsy is tested, specifically after the procedure. We teach clients to lay on the right side, basically to lay on the liver, to prevent bleeding. So we always put pressure on anything that is bleeding. In that same way, we're putting pressure on the liver to prevent that bleeding. All right, that wraps it up. Thank you so much for watching. Oh, who lives in the abdomen next to the spleen? The pancreas secretes insulin and digestive enzymes. The pancreas, islets of Langerhans beta cells to secrete insulin to open the cells and let sugar inside for energy. Ready? The pancreas secretes enzymes and insulin. The pancreas. Join simplenursing.com. Okay, hopefully you guys liked our pancreas song. You can get it for $1 on iTunes and even Google Play if you have an Android. And we also have 8 more songs in our full album. Simply search Simple Nursing on your music store. Now for pancreatitis. The pathophysiology is very simple. In pancreatitis, we have inflammation of the pancreas. So anytime you see the word itis, just think inflammation. So in pancreatitis, this inflammation comes from autodigestion of the pancreas. Basically, the pancreas's own digestive enzymes have accidentally activated early. Now, as you know, the main functions of the pancreas is exocrine and endocrine. The exocrine part is to produce digestive enzymes, which helps break down food and is a critical part of digestion. And the endocrine is for secretion of insulin and glucagon to stabilize glucose balance, which we cover in the diabetes lectures. Now, the enzymes are the key here. They are like ticking time bombs to break down and digest food. But when they're activated early inside the pancreas, they actually digest the pancreas. So the 3 key enzymes to know is protease, which breaks down protein. Lipase, one of the biggest affected by pancreatitis, breaks down fats. So just think lipids and lipase, lipid for fat. And lastly, amylase breaks down carbs or carbohydrates. Now, if the pancreatic duct is blocked for any reason, say from inflammation in liver cirrhosis or hepatitis, or let's just say a gallstone has floated down and got stuck, well, this means that the enzymes can't get out of the pancreas and into the intestine and accidentally prematurely activate within the pancreas. It's kind of like having a pirate ship, and you know how they shoot out cannonballs. But what if those cannonballs explode within the pirate ship and sink your ship? Well, in the same way, it's kind of like having these enzyme bombs exploding inside the little pancreas here, causing supersized inflammation as the pancreas digests itself. This is what is meant by autodigestion. Now, the causes are very simple. Again, think anything that can block this little tiny pancreatic duct. As you can see, we have a lot of organs closely fitted together here, kind of like an apartment complex. They all share this common bile duct, which branches off into the pancreatic duct here. So, common causes is alcohol abuse from years and years of inflammation, which ends up inflaming the little duct